series of lectures that we put on this year. We're really excited to have this caliber of physicians with us this afternoon who are really dedicated to supporting patients in our community in terms of early detection and diagnosis and treatment of prostate cancer. For those of you who aren't familiar with the foundation, we are a non-for-profit charitable organization that is dedicated to educating and patient support programs and research for cancer patients and their families throughout central and western Illinois. In your packets, each of you should have a brochure like this. I hope that you'll take that home and read it sometime and familiarize yourselves with what we do. And just to give you a little overview of kind of how we run these lectures, we'll usually have our panelists, our physician panelists, speak for about 5 to 7 minutes each. And then you may notice in your packet that you have just a blank note card. That blank note card is there for you to write down questions you have as you listen to the presenters today. And then once all the presenters have made their remarks, we'll take a brief break. You can help yourself to more refreshments, and then we'll start going through those questions and having the panel address those questions for you. Also in your packet is an evaluation form. If you would please complete this before you leave, it really does help us fine-tune these programs for you, and it gives us great feedback so we know what types of programs to host in the future. Before we get started with the formal program, I would like to thank Janssen Biotech, who's generously sponsoring this educational program for the foundation. With that, I think one of the things I did not do, and I hope the physicians are okay with it, we did put in your packet a bio sheet, which is a really condensed version about the accomplishments of each of these physicians. Unfortunately, if I took the appropriate time to introduce them according to their outstanding educational and patient care accomplishments, it'd be another half hour before we started the program. So I hope you don't mind if we just jump in to the program. And I think we're going to start with Dr. McVicker. That's what I've been told. So, surprise, surprise. So if you can come here, you can stay there, whatever you want to do.
I guess I was given the charge of sort of going over advanced prostate cancer, and I just wanted to highlight that this was an area where the field or care for men with prostate cancer really has changed over the last few years. And so if people are familiar, I listed here just the different agents that are now available for men with advanced disease getting treated for prostate cancer. And historically, that's really just consisted of hormonal therapy and the two agents, or the two groups of classes of agents under hormonal therapy, and then a single chemotherapy drug, docetaxel, that's midway down on the right-hand side. And then the remainder of these agents, I guess aside from zoledronic acid down in the lower right-hand corner, have come into the clinic really over the last, I guess now 3 to 4 years. And these include, so traditional hormonal therapy would be LHRH agonists that you may be familiar with, at least by trade names, in terms of Lupron or Zoladex. But in addition, anti-androgens, Casodex, and those work by different ways. But we now have newer androgen or hormonal therapy, and one of those that you may be familiar with is a drug called Xtandi or enzalutamide that's blocking the androgen receptor, and so sort of a next generation anti-androgen. And then another class of agents, androgen biosynthesis inhibitors as they're known, are actually reducing the production of androgens by interrupting some of the enzymatic pathways that lead to the production of testosterone and androgens. So even though we've been targeting hormonal therapy for a number of years, these agents we think do a better job at interrupting the stimulation of prostate cancer cells by testosterone or androgens as a whole. but sort of getting down into different pathways or different mechanisms by which to treat prostate cancer. Immunotherapy, which you may be familiar with from other disease sites, has actually been brought into the fold of prostate cancer. And an agent, Sapulosel-T, or known as Provenge, has been brought to clinic, and probably ideal for a group of men that are doing well and don't have much in the way of symptoms and maybe more slowly progressive disease, but certainly advanced metastatic disease. And then also targeting bone therapy or bone metastases. Radiation has been used for a number of years for men with localized disease and also to palliate bone metastases. But radium-223, or known as Vigo, recently was FDA approved for men with skeletal metastases and perhaps symptomatic from them. And then finally, in terms of good old chemotherapy, in addition to docetaxel, we've seen cabazitaxel or Jevtana been brought to clinic. And so all of these agents, enzalutamide, abiraterone, Sapulosel-T, radium-223, docetaxel, and cabazitaxel extend survival. So just over the last few years, we've gone from just really one agent that's been proven to improve overall survival, and that's docetaxel, to 6. So it's really kind of exciting. And the fact that it's not just several agents, but they all work by different mechanisms, which I think is important because not everybody's disease is the same. And then finally, in terms of supportive care, there's been bone-targeted therapy. For a number of years, we've been using zoledronic acid. And this isn't directly treating the cancer per se, but trying to reduce the fallout from the cancer, as a number of men with prostate cancer will have bone metastases and can develop complications thereof. And we believe that these two agents, zoledronic acid and then a newer agent, denosumab, both reduce the risk of those complications. So not only are we improving, treatment of advanced disease, but we're also, helping from a supportive and quality of life standpoint, improving, the lives of men. So I think it's actually a very exciting time for at least medical oncologists in this field, because we've been sort of long to come to the table, but now have a lot to offer. Thank you.
I'm Audrey Bajaj. I'm one of the physicians here at Illinois CancerCare, and I recently assumed the position of physician director for clinical cancer trials here at Illinois CancerCare. And everything that Dr. McVicker outlined for us is describing our current standard of care, so FDA-approved therapies for how we treat advanced prostate cancer. Our urologists and radiation oncologists who are present today are going to talk about, very shortly, PSA screening and some of the techniques, surgical and radiation techniques for earlier stage prostate cancer. Okay, just to kind of put that into perspective. I wanted to just do a brief intro to clinical trials. So Illinois CancerCare is very well known for our ability to conduct clinical cancer research. Okay, so these are cancer trials that have already been, or medications, drugs, investigational agents that have been tried in the earlier phase of research, so on animals, etc., and even the earlier phases of human drug research. So now these drugs, we have a safety understanding of the drug, we know how to dose these drugs appropriately. Now we're trying to apply them to a larger patient population, focusing specifically, let's say, on prostate cancer patients at different stages of their disease. Traditionally, a lot of the cancer trials that we have focus on advanced prostate cancer patients, but slowly we're exploring the realm of earlier stage prostate cancer and how we can incorporate some of these exciting agents that Dr. McVicker was talking about into initial prostate cancer diagnosis and management. So of our clinic locations, we have 12 clinic locations and 14 physicians, 4 gynecologic oncologists. This is a general map of where our clinics are located. Peoria remains is our headquarters, essentially. So the majority of our research happens here. research team, their research associates, navigators are located here. However, most of our cancer trials are available at our satellite clinics. Okay, there's very few, I would say, that are Peoria only, and it's for the earlier stage studies. So like phase 1 and so forth. We've been active in clinical trial research from, as you can see, first patient was enrolled in 1979. About 10,000 patients so far have participated in clinical trials. We've received 2 American Society of Clinical Oncology Clinical Trial Participation Awards, which is a very great honor in the field of medical oncology research. Now, this is made possible not only from all the satellite clinics that we have and all the patient outreach that we have access to, but because of the hospital affiliations that we have established, and with the radiation oncology centers. So our urologists in Peoria and the outlying communities do a fabulous job of working with us, and so do our radiation oncologists. So we're very thankful to have them here today to talk about exactly what they do for our prostate cancer patients. Sources of clinical trials. Well, the majority of the trials that we have in our menu, we have anywhere, essentially over 100 clinical trials we have on our menu. And the majority of them are NCI sponsored, so National Cancer Institute government-sponsored research programs. We recently were awarded a multi-million-dollar grant from NCI to be part of the NCORP, which is the NCI Community Oncology Research Program. And that's going to be a very nice venture for us because it's going to give us the opportunity to acquire even more prostate cancer trials. Industry-sponsored trials are also available here, and we do have some of the industry representatives. And of course, Janssen, who provided the grant. Historically, we've had a few investigator-initiated trials, meaning, let's say Dr. McVicker was interested in a certain compound, and he wanted to work with a pharmaceutical company to develop a clinical trial and see if we could, start that trial right here in Peoria. We have infrastructure to even support something like that. So these things happen at large academic centers. However, due to the strength of our clinical trials program, we could do that going forward. We're also part of large consortiums such as University of Chicago, and we're joining with University of Rochester for a lot of their supportive care studies. So treating prostate cancer with investigational agents is one part, right? The second dimension to treating a prostate cancer patient is understanding all of the supportive care needs, such as sexual dysfunction, depression, weight gain, bone density loss, etc. So there's a lot of trials that we have yet to add to our portfolio that I'm interested in doing. So this is a list of our current prostate cancer trials. This is going to grow, okay? We are in the process of at least acquiring 4 more. And of those, 2 of them are not even for these specific spaces. In prostate cancer, you're going to hear that very often. What space of prostate cancer are we talking about? As you know, it's a long course, all right? It's a long clinical course. You must have often heard it's a cancer that you die with and not die from, all right? Which means that from the time of diagnosis to till the end, you're going to go through different spaces of treatment. And the trials that we have, this one, adjuvant means that you've had surgery, and we are working to give treatment along with a surgical procedure, such as a prostatectomy, or with radiation treatment to treat the prostate cancer with the intention to cure. And this one trial is looking at adding something like Lupron or Firmagon to radiation treatment with the intent to cure, and it's for intermediate risk prostate cancer. The other list of trials are looking at novel agents, like the TAC-700 is an exciting, potent agent that is basically trying to do similar things to the approved agents like Zytiga, for example, or enzalutamide, in combination with hormone therapy for metastatic prostate cancer patients. We have this other trial, the one all the way down at the bottom, which is looking to combine 2 FDA-approved therapies, enzalutamide, the Xtandi, with the abiraterone, Zytiga. So both of these drugs are FDA-approved. And this trial is looking at combining them to see if we would be able to get a stronger hold of prostate cancer that is advancing, either by PSA or by the amount of disease noted on the scans. So as of now, that's not something that physicians can prescribe. You can only have access to that combination if you're on this trial. And there's many more that we're hoping to bring forward. There's a special space, all right, in between the adjuvant, all right, you get treated for your prostate cancer, and then now it's in the bone or it's spread. There's a space where patients have PSA that keeps going up, all right? The PSA after you get your treatment for prostate cancer should be undetectable. But oftentimes we see that the patient's PSA starts to rise. And it's a time of a lot of anxiety, and it's a time that our radiation colleagues and our urologists have to work very closely with patients to help them understand what do we do. A lot of the prostate cancer research is starting to move towards this M0 space, meaning there are no known areas of metastasis. So the prostate cancer, when you do a scan, is not visible. However, the PSA is up, meaning the cancer's there, it's micrometastatic. It's invisible prostate cancer cells. So there are 2 studies that we're looking to acquire. Both of them have already showed quite a bit of promise, and they're in the phase 3 portion of their development, which means it's a large multi-center. We're talking about hundreds of centers. The Aramis study is multinational, so it's in like 320 countries or something. So these are large studies. To have access to these studies here is going to be an asset to Central Illinois patients with prostate cancer. And so hopefully we can do something to intervene in these rising PSA patients before we have to start talking about how to treat advanced prostate cancer. So with that, I'm going to hand it over to Dr. Carpenter to make some remarks about radiation oncology and PSA screening.
Can you hear me without the mic? Okay. How many of you here are diagnosed with prostate cancer, if you don't mind sharing? If you could raise your hands. How many of you have a loved one who's diagnosed with prostate cancer? Okay. All right. I could have talked about radiation treatments, but I thought I would direct my remarks to something of more general interest. And I thought I would go over questions that I get in the clinic about PSA. So this is just, I thought that these are of interest because these are questions I always hear from men who have prostate cancer and are either undergoing treatment or trying to decide if they need to undergo treatment. So the first thing is, what is PSA? Prostate-specific antigen. Well, it does something. It's a protein that is produced by the prostate gland. Now, tiny, tiny amounts of it are produced by other glands in the body. But 99.99% of it is produced by the prostate gland, so it's something that's mostly found in men, okay? So it's an enzyme, okay? So the next question then is, does it do anything? Well, it has a role in nature. It wasn't there just for us to use as a marker for prostate cancer. What it does is it liquefies viscous secretions to allow sperm to swim freely. Okay? So that's why your body makes the PSA. It helps in reproduction. That's all nature cares about. When my PSA goes up, does that PSA do anything to me? No. The PSA itself doesn't do anything to you. The problem is, if the PSA goes up, 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 it's maybe a marker for something that is going to do something to you. In other words, if you have cancer in your bone and the PSA is going up, the symptoms come from the cancer in the bone, not the PSA per se, all right? So what causes the PSA to go up? It is always normal to have some PSA in your blood unless your gland has been removed. Even if you've undergone prostate cancer irradiation, you may have a certain amount of PSA in your blood that is detectable because the gland was not removed. Now remember, the teeny weeny amounts are made by the salivary glands and the pancreas. So if you get an ultra-sensitive research test, you'll find PSA in a woman. It's a substance found in nature. But for the clinical tests that we do, it's really only detectable in men. So anything that perturbs the normal function of the prostate gland can make the PSA go up in the blood. So there's something called benign prostatic hyperplasia. The gift that keeps on giving, because you're a man, the PSA gets locked, the prostate gland gets bigger as you get older, and then some it gets really big, and it makes it trouble for you to pee. Well, that's going to make your PSA go up. And if some guy comes in, they could have a PSA very high because they've got a very large prostate gland, not because they have cancer. Or if the prostate gland becomes inflamed for some reason. Now, medicalese for inflammation is itis, tonsillitis, appendicitis. Why can't you have prostatitis? You can get an infection of your prostate gland, and that will cause the PSA to go up as well. If my surgical colleagues come at you with their needles and start stabbing you in the prostate, that can cause the PSA to rise temporarily as well. But also, what we're interested in is your PSA can go up as a result of prostate cancer. Now look at this. Normal PSA is related to your age and your ethnicity. Okay? So the older you are, your PSA may be up to a certain degree just normally, just because you're an older man of a certain ethnicity. So, well, when you get the PSA, doc, what do you look at? Well, first of all, I want to know, how high is the PSA? If the PSA is 2 or 3, that's different implications than if the PSA is 23. Okay? Now, is there any obvious reason that the PSA should be elevated? Do you already have a diagnosis of prostate cancer? If so, have you been treated for the prostate cancer? If you go to your primary care doctor, your family practice doctor, and they do a PSA and it's high, higher than normal, most of the time that's not from prostate cancer and we have to sort it out. The next thing that I really want to know is, how fast is it going up? We will calculate something called the PSA doubling time. How fast does it take the PSA to go from 1 to 2, 2 to 4? That's much more interesting to me even than how high is the PSA. Is it going up, or is it whoosh? It has different implications. I heard you shouldn't check that PSA test. You're supposed to be asking questions. Okay. The role of PSA for screening for prostate cancer is very controversial at this time. Here's my take on it. The U.S. Preventative Services Task Force recommends against using the PSA as a screening test for prostate cancer. Their comment is, with everything under consideration, there is no good evidence that if you screen for PSA, you will help men live longer than if you don't screen for PSA. Overall, the whole population. Okay? However, the American Cancer Society, no, I'm sorry, that's wrong. The American Society of Clinical Oncology, ASCO, a big umbrella group for everyone who takes care of cancer, surgeons, doctors, radiation oncologists, disagrees with this conclusion. The reason is that you've heard of garbage in, garbage out, right? the data that you put into your computer determines the quality of the output. And our point is that they misinterpret the data. They went in with a specific conclusion in mind, and they found the data to get to that conclusion. In other words, they say that there's a significant chance of you being harmed or dying during prostate cancer surgery. That is just not the case. Surgery is so sophisticated now, anesthesia is so sophisticated now, the risk of you having serious harm to you from surgery is very low. The same with the biopsy. So I think we are more in favor of appropriate screening. However, what you need to do is you need to make sure you're seeing a doctor who won't just knee-jerk treat everybody with prostate cancer, even the men who don't need it. There's maybe 250,000 men a year who are diagnosed with prostate cancer. A lot of them never need treatment. And you just don't want to go into a treatment mill while they're putting you right into treatment. So you have to have a thorough and frank discussion with you and your doctor before doing any screening study about what is the outcome of that test, be it positive or negative, so you understand what you're buying into. However, if you already have a diagnosis of prostate cancer, that no longer applies, okay? We are now using it to follow your cancer and monitor treatment, so there's no controversy at all. I'm going to check your PSA. That's about that.
Dr. Mackenzie McGee with radiation oncology at OSF is going to talk to you a little bit about.
I'll talk a little bit about radiation.
So I'll talk to you a little bit about radiation therapy, what it is, and why we do it. So just a little bit of background, in case you're wondering what is radiation. It's basically high energy x-rays that we use for treatment. We're able to target them to the prostate or any surrounding tissues that need treatment, as determined kind of by the overall workup of a cancer, and so we use it for therapy. For prostate cancer, how we direct treatment, or what treatment options are available for a patient, really depend on something we call risk groups. Some of the governing organizations that make a lot of the recommendations for prostate cancer treatment have specified a lot of different risk groups to identify those patients who need more aggressive therapy and those patients who may need no therapy at all. Some of the things that determine that is a Gleason score, which is basically what the pathologists look at under the microscope when they look at a sample taken by the urologist for a biopsy. The PSA, as we just heard about, and then the extent of disease based on any other studies we might do, something like a CT scan, which would allow us to look at things like lymph nodes, where cancer can spread, or potentially a bone scan, which lets us look at the bones to see if there's any spread of the disease. And those types of imaging studies are all based on those factors and how high of a risk we think there is for us to even need to look at those things. Radiation therapy is a treatment option for most patients who need some treatment for their prostate cancer. In terms of radiation, it's really a very mixed group of treatment options, really. There's what we call standard external beam radiation, which is essentially a machine that creates these high energy x-rays that kind of goes around you and delivers a treatment. There's no invasive component to that type of treatment. And there's a few different things that if you're ever, for those of you who have prostate cancer or loved ones and you're kind of looking around trying to read and understand all these things about radiation, there's a few different things you'd see described. One is, they call it 3D conformal radiation therapy, which is basically using imaging to help us deliver a very high dose just to the area we want to treat.
something called intensity modulated radiation, which lets us get even a little bit more sophisticated to increase our dose to the prostate while decreasing the dose to things like the bladder and the rectum that we certainly want to avoid dose to. Image-guided radiation is something that's come along that really helps us be even more targeted with our therapies. And it's typically something that your radiation oncologist does on a daily basis during treatment because the prostate actually moves quite a lot in the body. And that's a big factor for when we're treating prostate cancers. Based on how full your bladder is that day or how full the rectum is, the prostate actually moves a fair amount. So we'll use imaging on the treatment machine to help us be more precise with our radiation to ensure we can protect those structures that need protection and treat the cancer effectively. One thing that is also a good treatment option in some patients is called brachytherapy. It's sort of an inside-out type of radiation where we really have the ability to deliver even higher doses biologically than we can with external radiation. Typically, there's two ways of doing that. One is with something called high-dose rate brachytherapy, and that's really a temporary implant is how I would describe it, more of a procedure type thing. The other one is low-dose rate brachytherapy, which is a temporary implant or seed. They call it a seed implant sometimes. The other thing that people commonly ask me about in the clinic is what's the role of proton therapy. It's something that's used at some bigger academic centers. And really the goal behind it is to try to minimize the risk of damage to some of those normal tissues while being able to deliver very high doses of radiation to the prostate, which we've shown improves how people do. So proton therapy right now has not shown to be superior to the other methods that we have, but it's an area of ongoing study. So what are some of the side effects of radiation? That's probably one of the most common questions we get in clinic. The most common acute side effects, meaning happening as you're going through treatment and shortly thereafter, would certainly be some fatigue, the sensation that you have to urinate more frequently or urgently. Sometimes people have some inflammation in the rectum, which may manifest as feeling you have to go have bowel movements more frequently or urgently. Some late side effects that we look at would be erectile dysfunction, some inflammation in the bladder, and potentially some increased frequency of bowel movements or urination in the long term. With modern radiation techniques, the rate of having very severe complications in the long term is actually pretty rare. I talked a little bit about these risk groups, and there's even more than just the three I'll present, but this just gives you an idea of, prostate cancer is a very broad range of treatment options. For patients with low risk disease, meaning they likely have a very low risk of this affecting kind of their long-term survival, is something that we will take into account their life expectancy versus how much of a risk we think that prostate cancer poses to them. One of the treatment options is actually active surveillance, where it's not an active treatment, but we're actively following the patient to see which patient's going to have a biologically different tumor that maybe shows us signs that it wants to progress. And so in those patients, we actually spare them treatment up front, and we potentially spare them the side effects of treatment. Because no matter how good any of our treatments are, there are side effects. The downside to something like that can be some anxiety associated with not treating a cancer. And so certainly we take all those things into account when making decisions with patients. Surgery is another option. I defer that discussion to my surgical colleagues. And then radiation therapy we discussed. One option is to just do external radiation alone. That's a good option for patients who aren't able to have things like the brachytherapy, which is more of a surgical type procedure. And then, we really have to, when we do brachytherapy, essentially we have to go through some of the same screening procedures as somebody might do for a surgical procedure. So it's a more selected group of patients. But overall, the brachytherapy actually allows us to give very high doses of radiation, has excellent outcomes in patients who are able to receive that therapy. In intermediate risk prostate cancer, often will have the options of surgery versus radiation. It's in this group of patients we start wondering if we need to add, and we call androgen deprivation therapy, which our medical oncologists have already spoken about a bit. One of the trials that Dr. Bajaj was mentioning is actually one that is pretty important in our field and looking at whether patients with this intermediate risk prostate cancer need hormone therapy in the face of modern radiation techniques. We're able to get higher doses than we used to be when we did the initial studies that showed us some benefit with using hormone therapy. So we're seeing if possibly with modern radiation, can we spare patients in this risk group the side effects of hormone therapy. For high-risk disease, typically can either look at surgery, and we're certainly going to pay close attention to the pathology report afterwards to see if the patient needs any radiation after, or we'd be looking at doing radiation therapy with some long-term hormone therapy. And the reason for that is those studies that have been done with some of the long-term hormonal therapy have shown improvement in survival in those patients. One of the keys to both the intermediate risk and high risk, I would say, is that some of these patients are eligible for doing both external beam radiation as well as that inside-out type of radiation, the brachytherapy, to really give much higher doses than we're able to achieve with external radiation alone. Some of the best rates in terms of preventing failures with PSA rising are actually using brachytherapy. So that's a very good opportunity for us to give very high doses to a very, very targeted area. So in conclusion, I would say one of the most important things right now, and has been alluded to already, is identifying patients with low-risk disease who don't need treatment at all and who we can potentially spare the side effects of any of our therapies. And then as well, just to continue to define those patients who need hormonal therapy and how long and all those things. Thank you.
Thanks, guys, for having me today. I appreciate it. First of all, what Dr. Carpenter said was key. He talked about the United States Preventive Task Force. And in May of 2012, they said, do not screen for PSA. Risk outweigh benefit, treatment is not warranted. I don't know where they came up with the recommendations. I don't know if you guys realize as we started screening for PSA, we've gone from 40,000 deaths a year to about 26,000 deaths annually for prostate cancer. We diagnose anywhere between 200 and 250,000 men a year with prostate cancer. So it created a lot of havoc for us urologists because patients came in and didn't want their PSAs tested. I actually got called in by Caterpillar, by their administrators, their healthcare providers, and their attorneys because they were going to stop screening for PSA for prostate cancer. We had about a 2-hour debate about it. And thank the Lord they didn't change their minds. So I think screening is key. I think the PSA is not a great test, but you have to watch the PSA velocity. You have to see the change in PSA over the years on patients. When people are stagnant and are always high, that's a good sign. It means they don't have probably prostate cancer. If they start going up with a velocity greater than 0.75 a year, that's a bad sign. So if the PSA is going up with their abnormal rectal exam, and by the way, the PSA will find prostate cancer on average 6 years before our digital rectal exam will. So it's still a decent test. It's not great. So if you find someone you want to do a biopsy on, I know biopsies in the past were horrible. Some of you guys had biopsies 15 years ago when you didn't numb the prostate, and every time you heard the click, you jumped. When we took 6 biopsies, you felt 6 pokes in your prostate and it hurt like hell. It's a different ballgame today. Now when you come in, the first thing we do is most of us will do a rectal swab to make sure you're not going to get sick from a biopsy. A lot of people have resistance to antibiotics we use for prostates, for the biopsy of the prostate. So now we'll do a rectal swab to make sure that the antibiotics will work against your flora of your colon to make sure you don't get sick after a biopsy. There's about a 4% incidence of people coming in really sick after prostate biopsies. It's bacteria going in their bloodstream. Literally in about 18 months since I started doing the rectal swabs, I have not had anyone come in sick, and I do 3 to 5 biopsies. So I truly believe in the swab. So you come in, you get the ultrasound probe put in, and next thing you get numbed. After you're numbed, you don't care how many biopsies we take. Honestly, it's not a big deal. And we take anywhere between 12 and 18 on everyone. You don't want a sampling error. The old-fashioned, the old-fashioned 6 is out the window now. And I just decide on A, my concern if they really have it, and B, how big the prostate is. The bigger the prostate, the more the biopsies they get. The most I'll take in one setting is 30. I lose count after 30, so that's about enough. That's called saturation biopsy. So let's say I do a biopsy on someone, I'm convinced they have, and the biopsies come back negative, or they come back with prostatic endothelial or PIN or ASAP, atypical small acid proliferation. Then once you got these two diagnoses that are precancerous, or you don't have cancer at all and you're suspicious. Well, now with imaging as good as it's gotten, we do MRIs. And we have a 3 Tesla magnet OSF, so we put you in an MRI, and literally they'll show us the lesions. And they'll do all sorts of dynamic curves, and they'll say, here's the lesion. That's fine and dandy, but then you got to put the patient in the MRI again for a biopsy. And sit there in an MRI, it's a closed MRI, not an open MRI, and have a probe up your rectum. You're claustrophobic already, which most people are. And you got somebody your rectum to taking biopsies, it's absolute hell. So there's something called fusion coming out now that we're about ready to start at OSF, where they get their MRI, they can fuse that image with the ultrasound, and we can do an ultrasound and guide that biopsy right where the abnormal lesion is. Because we can't see the lesion on ultrasound typically. Not what they see on MRI, it's totally different. Now it tells exactly where to biopsy, so it's mindless. I mean, they say biopsy there and showed you right where in the picture on the prostate, where to hit the target, and then you can still do the other 12 biopsies also at the same time. So we're coming a long way with diagnosing and treating prostate cancer, we really are. So now let's say you get the diagnosis of prostate cancer. Then you got to look at a bunch of factors on how to decide how to treat it. And this is the art of medicine. There's no cookbook. You can't do what your neighbor did. They always say, here's what my neighbor had done. Well, it doesn't matter what your neighbor had done. First of all, you got to look at the age of the patient. When I look at the age of the patient, I think when you're over 70, I have a hard time recommending surgery. And I think the risk outweighs the benefits. The rate of incontinence goes up. The rate of erectile dysfunction 100% after 70 years surgery. You got to look at their PSA. You got to look at their Gleason score. That's the score they give you after your biopsy. A high score is bad, a low score is good. And then you got to look at their voiding patterns. I mean, if these guys have obstructive voiding symptoms, the last thing I'm going to do is send them to the doctor McGee to radiate them. It gets worse. If they have no obstructive symptoms, radiation's obviously a great way to go, especially I love the high dose she talked about. We place the needles and then we do external beam. It's a combination therapy and it works wonderfully. But everything has to be tailored according to the patient. Everything's individualized. In the future, we're doing genetic testing now on prostates. So we can do genetic testing on the tissue and tell you a risk stratification if you have a high-risk disease, what a chance it's going to spread over the next 5 years. I just did this with a patient who had his prostate removed, had a very high Gleason and a high PSA, and he told me he has an 18% chance of spreading over the next 5 years. The genetic test cost him $500 out of pocket. So I think that's where we're heading in the future is genetic testing. We just started a cancer clinic, and I think Gary's going to be doing a lot of this genetic testing, but it really doesn't matter for us because it is the future, and that's what patients want. So prostate cancer is always evolving. The surgical treatment options, which I'm supposed to talk about, you can either have it open or robotically. I personally think robotic is a very big gimmick. I've always thought that. I was the first person to ever do a robotic prostate in the city. I was probably the first to bag it. I did about 6 cases and it wasn't for me. I think in the right hands, like the Wall Street Journal said, I think it's a good procedure. But by the right hands, it has to be someone doing 3 to 5 of these a week, not dabbling. It has to be a high volume center. Otherwise, the complication rate is very high. I think the same is true with open prostatectomies. I think unless you're going to someone who has a high volume, your erection rate is lower and your incontinence rate is lower. But then it's just a difficult decision when you decide to surgery. Open, robotically, or perineally, which is a very difficult surgery to do, but I think has a very good outcome. So patients get very confused. When I diagnose them, I always say, go home, read about it, pray about it, and come back in 2 to 3 weeks and we'll talk about it. Because we don't want to make any decisions any rashly. I mean, there's time. Prostate cancer is not going anywhere in 3 weeks. But it is a very confusing cancer, and I wish that task force never came out because it made our life difficult. Gio?
I'm okay. I think everybody can hear me. I guess the good thing about going last is most everything said. But I think I'll expand on what's been said here in terms of the initial assessment or treatment of prostate cancer. And if you can't hear in the back, just raise your hand and I'll speak up a little bit. The task force that Dr. Rash had referred to really did, if you want to say, change our perspective. My feeling is very similar to what Tom said. I don't agree with it. Most urologists don't agree with it, but the reality is that there are people who have prostate cancer that probably are never going to ever have a problem with it. And I think what our challenge is going to be over the next 10 to 15 years is to find the people that don't need to be treated and not aggressively pursue diagnosis. It's a little bit difficult, and I think to do. I mean, you're going to have the genetic aspect of testing that I think may replace serial PSAs. The PSA by itself, as Tom said, is not the best test. That's what we have, though. It's easy to do. It's relatively inexpensive, but it does generate a lot of false positives. What I worry about, and I think Tom probably the same, is the false negatives, and also the men who now, because of the fact that the recommendations have become PSA is no good, don't even get it because you're not going to die of prostate cancer, who aren't having symptoms, aren't getting assessed. And we don't want to speak based on what we see, but anecdotally, I've been doing this for 25 years in Peoria, well not 25, but 24 years in Peoria, close to it. 2 weeks ago, I was on hospital call. I saw 2 patients who had presented initially with widely metastatic prostate cancer, spinal cord disease, had to have decompressive laminectomies, never seen it before. Now, obviously, these gentlemen were both 60-ish, working, had no problems, no urinary symptoms, and wildly elevated PSAs. But what my point is that if you can find those 48-year-old guys who are going to be predisposed to prostate cancer, I think that's where the challenges are going to be. If you look back critically, have we probably treated people who are never going to have problems with their prostate cancer? Yeah. But we are worried about guys who are going to become those 60-year-olds, 65-year-olds who I saw a couple weeks ago. So that's just more of a reflection. So the imaging techniques that Dr. Ratchet talked about, I think are going to help us identify people who we're concerned about as far as their high PSAs, we're having negative biopsies. They're going to help us identify those men who are electing to undergo active surveillance, which in our practice's hands basically is the gentleman with really small amounts of low-grade prostate cancer, relatively low PSAs, health can be either good or bad. Age is really not a limiting factor, though young guys you always get more nervous about. And as I got over 50, young kind of became a lot older. But the active surveillance fellows who are going to opt not to treat, I think the MRI is probably going to be a very useful tool to try to make sure, because we know that 20% of those guys have worse disease than what we see on our initial biopsy. If you take their prostate out, you know that. So, and there's a certain percentage of those guys who are going to fail over the next couple of years. So if you can identify those active surveillance patients, with whether it's with genetic testing and markers like Dr. Rash was talking about on their prostate biopsy tissue, or by new imaging, those might be gentlemen who it might be reasonable for them to reconsider whether they want to be treated now if they've got a high risk of progressing in the next few years. So I guess I'm going to I'll conclude. I don't know how you want to get the questions, so we will bring it back.
Well, that is it's an interesting question, because once you are exposed to radiation, you never walk away from that exposure. And there are side effects that can develop over many years. Many years means decades. What we're mostly interested in is what is going to happen over the first 5 years after radiation therapy has been completed. So the bulk of what we see in terms of long-term complications is seen within a few years. For example, if you get external beam radiation therapy, within 2 years, if you have normal erections, about 40% of men are going to have trouble with having erections too soft to achieve intercourse. So that's kind of the time course that we're talking about. The chance that you're going to have rectal bleeding that requires something like putting a colonoscopy up your rear end and doing a laser zapping is about 1% with modern techniques over 5 years. However, suppose you get radiation therapy when you're 40 and you're going to live to be 85, 90. There are certain things that can happen that are unpredictable that will not show up for 30 or 40 years. We have seen men have damage to their pelvic bones such that the bones started to collapse 40 years after radiation. We would think that with our modern treatment techniques that this is much less likely because we're a lot more careful. But there are weird effects that are very rare that can occur decades later. Generally, when we speak to you, we're talking about things that will happen within the first 2, 3, 4, 5 years. I don't know if that answers the question. I don't know.
What's the long term?
What?
What is the long term, 3, 4, 5 years?
It depends on how long you're going to live. Seriously, most men who get prostate cancer get radiation therapy are 60, 70, 80 years. We're interested in what's going to happen over the next 10 to 15 years. Okay? So this is why when someone is very young, suppose someone is unfortunate, they're 42 and they get prostate cancer and they come in, we'll look at them and say, well, we could give you radiation, but we don't know, we cannot predict what these severe long-term effects might be. That is decades later. But for someone who is of the normal age that we see, we're concerned what could happen 10, 20 years down the pipe. And mostly that happens within the first 5 years.
Normal age of the people you see is what,
Well,
60, 50?
if we see someone who is under age 50, we really want them to talk to the surgeons before they talk to us because of that. If we see someone from age 50 to age 60, we also want them to have a serious conversation with the surgeon because they're going to be exposed to the effects of radiation over 30 plus years. Sometimes surgery is not going to work out for them, and then we're worried, well, we better cure the cancer now and deal with the chronic effects later. The other thing is you have to remember that the treatment for these chronic effects is improved, particularly with something called hyperbaric oxygen. But generally, if someone is over age 60, it's sort of like all the radiation treatments are on all the radiation options are on the table. We will treat someone under age 60, but we need to make sure they understand what they're getting into.
I think I would add to that, that's why in patients, especially in that 50 to 60 age group, we often recommend that brachytherapy because you spare all those extra normal tissues outside the prostate for the most part of high doses of radiation to try to alleviate some of those concerns about the bone, and things. Certainly there could be late side effects, but you hope that you're minimizing what those side effects may be.
So this is with regards to the prostate sweep and infection risk. Question states that 3.5 years ago, the patient had a biopsy and it did result in sepsis and hospitalization in the intensive care unit. Current PSA is 16 and there is an MRI that has been ordered. There were some hot spots on the MRI. MRI-guided biopsy is planned for next week. Patient is going to be on an antibiotic a day prior and then for 3 days post. So is this going to be sufficient to guard them from a recurrent sepsis fiasco?
Typically, you're placed on Cipro. I think that's what you're put on before. And these are quinolone-resistant bugs. It's always E. coli and always quinolone-resistant. I'd say get a rectal swab from your rectal flora, and it'll give you a profile of what antibiotics work and which ones don't. That's what we do. I culture everyone's rectum.
I didn't know rectal swab.
You take a little Q-tip and put it in the rectum, put it on an auger, and 2 days later you give you an answer. It's pretty mindless. It is. It's perfect. I haven't had a septic patient since January of last year now. I mean, so.
Yeah, the appropriate antibiotic prophylaxis
Right.
is key to the success rate of
If
these
you get on Cipro again, you
procedures.
get septic again.
Yeah,
What about Levaquin?
Same thing. The quinolone.
it's still a quinolone.
It is the same.
Yeah. It's like Ford Mercury, it's the same car, just different name.
This patient is 74 years old and is African American, has a PSA of 5. Is that a life threat? What would you say, Dr. Colombo? How do you interpret numbers?
That's a point in time, and it depends on what their prior PSAs are. I think that with just that single point, with the rectal exam, and even with a normal rectal exam, that person's at a 20-ish% risk of prostate cancer. And you have that conversation and discussion, and they've got options of waiting, repeating PSAs. They're probably at low risk, relatively low risk for immediate life-threatening consequences, but they may have a aggressive cancer. I mean, Tom would say the same thing. I've seen aggressive cancers with metastatic disease with a PSA of 7. So you can't say just because a PSA number is what it is, that it's okay. But the odds are probably low of any immediate issue.
Dr. Asher, do you, are there any normograms or tools that patients could use online that you would recommend?
Well,
You know,
once
there's
you're
these
diagnosed-
patient-friendly tools. I'm sure they come to you with.
There are. The one after you're diagnosed, I use the Parton nomogram on everybody.
Mhm.
And it's called the Parton nomogram. P-A-R-T-I-N nomogram. I use it on everyone. I give them a spreadsheet. It gives you percentages of likelihood of organ-confined disease, extracapsular, involving the seminal vesicles or lymph node disease. And it gives you a percentage of likelihood of each one. I use that on everyone after they're diagnosed. Before they're diagnosed, I really do watch the PSA and the PSA velocity. On this 74-year-old African-American with a PSA of 5,
Mm-hmm.
if his did rectal exam is normal, I give him the option of biopsy like Geo said. I want to push it. I give him the option of it. If he wanted to do it, I'd proceed. 2 years ago, I wouldn't have pushed it. I would have strongly discouraged it because I was having a run of sepsis patients. So I was scared of biopsying people, I'll be honest. I was trying to discourage anyone over 70, unless I was positive they had disease.
I don't need that.
Okay.
My situation was in 2000, I had the operation. I was diagnosed as prostate cancer.
You had your prostate removed?
Yeah, in the year 2000. So this is 2014. Everything's fine. About 6 months ago, I took the PSA test, and it was up to 2. Then they gave me a shot, and it went up to 5. So I gave that's my problem. But they told me everything's okay. I'm all right. So that was my
So your prostate was removed though?
death. Complete.
Now it's a recurrent cancer and if the PSA doubling time's fast enough where
That's what I wanted.
that's when you either do an MRI and bone scan or you get a PET CT, one or the other. The problem with our PET CTs are not very sensitive.
Right. Well, that's what I'm questioning. My doctor, only thing he did is he gave me another shot, some long needles, gave me another shot in my stomach, and we'll wait another 6 months for another test.
I think you need to see an oncologist myself. I don't know if Dr. Colombo agrees.
Well, I think that you probably have some, you've got some disease somewhere. So it's a matter of trying
I
to
figured that, but
find
I
it.
just wanted to hear you told me I'm okay. Don't worry.
Yeah. Yeah, well, you can see, the lesson there is you can have late recurrences. And when I see fellows, they've had their prostate out, and 6, 7 years down the road, you kind of feel like, almost I don't want to say wasting their time by having them come in once a year, but that you need to continue with a lifelong PSA at least once a year if you've got your prostate removed. You're never, I don't want to say you're never disease-free. I mean, you like to think that you are, but there's always that possibility. And I've seen 10-year post-prostatectomy recurrences where guys thought that it was gone and it wasn't.
We just had one in the clinic yesterday. He had his prostate removed in 2003. His PSA was low. He had negative margins. 2012, his PSA was 0.2. Didn't show up. Came in 2013. His PSA was 0.4. We did radiation after our imaging showed no distant metastasis. His PSA is now 1. So obviously he has a distant metastasis we missed. But it is there. Our imaging's just not there to pick up some of these metastases right now.
And that's what I was alluding to with this M0, all right? M0 meaning that M1, it's a staging jargon that we use. M1 means that you've got prostate cancer that we can see on the scan. M0 means your PSA is going up, but we don't know where the disease is. So this is a realm where you'll be seeing your urologist, you might be seeing a radiation oncologist, you know, you should certainly be seeing one of us
Yes.
to help you kind of sort through what needs to be done next. All right, it might be okay for some of you to just watch this and do the PSA, you know, doubling time, you know, surveillance, whereas others it's not okay because it's already declared itself to be more aggressive. And hopefully, you know, we'll get these studies going here pretty soon, and you might be a candidate to have access to these medicines that have already shown that they can drop that PSA back to as low as it can go. Okay, so there are options, and that's an excellent question because it brings together why we need that multidisciplinary approach, why we need these three specialty groups to come together to help a patient, you know, through their prostate cancer journey, because it's a long one.
And for patients where we think, you know, potentially the disease isn't outside of the prostate area, we think it's still localized even late after a surgery, potentially radiation can be used for what we call salvage treatment, meaning treatment that we think the disease is still local and potentially can provide some benefit.
It's a large group of men with a biochemical recurrence after initial treatment for prostate cancer. So by biochemical, I mean just PSA only. And it's a varied group of men. So a portion of those men will have aggressive disease, but a number of those men, and there's good retrospective data to support this, go years, 15 years, before we can detect anything abnormal in its gene. So just because the PSA starts rising after initial treatment, it doesn't necessarily mean a rapid course to the disease for a lot of them.
Next question is, are there risk factors related to the environment? And what about prostate cancer genes?
There are, I guess, the environmental, I've got to say, I don't know of any others. Been talk about high animal fat diets as being risk factors, and that may relate to what kind of effects on a man's hormonal status that can cause. But I think that's something that's been out there. From a genetic standpoint, there are genetic markers that are now coming to be commercially available. In other words, you can order tests on tissue. There are genetic, I don't know if there are strict genetic tests that you can run on serum at this point that are commercially available. You might know.
I'm not aware of many on serum per se. So if you're familiar with early stage breast cancer, there's a test called Oncotype that can help women sort of determine their risk for recurrence and need for potential chemotherapy after treatment. And there's similar assays now available for prostate cancer, but not necessarily all that widely used as of yet.
I think it's not clear what they're going to help us with.
It's more as just to help crystal ball risk of recurrence, but it doesn't really necessarily help you make treatment decisions. Or tell you what to do, I should say.
If I can open up a can of worms, in terms of what you're going to be exposed to in the environment, it'll have the most impact on your prostate cancer. For men, frankly, it's testosterone. There are a lot of men out there who have a low testosterone level, and they're placed on testosterone. Now, this will not induce or cause a prostate cancer, but it may cause a prostate cancer that's already present to cause the PSA to go up more quickly. So it may unmask a prostate cancer. So in terms of what you might be exposed to in an environment, that there's really nothing that I know of that you have to worry about, but this medication may unmask a prostate cancer in a man who's otherwise healthy.
And not to make the can of worms worse, but there's some unorthodox thought that, I mean, there's enough that, I don't want to say out there, there are people, proponents of testosterone therapy in men who have low testosterone states that actually, and this is their opinion, is that, not necessarily mine, that it's actually the testosterone-estrogen relative ratio in men that low testosterone state men, in their opinion, may actually have higher prostate cancer risks because it's their estrogen-testosterone ratio that might be the prostate cancer trigger. Nobody knows, but it's an area that, whether it's the testosterone or the estrogen, you can say it's one of them. Something's happening from a sex hormone standpoint that is affecting men, and testosterone gets converted to estrogens in man's body, so there's that aspect of it. So.
From a medical oncology research standpoint, there are multiple studies looking at PSA failure, so rising PSA levels, patients and doing repeat biopsies or even testing their original prostate cancer biopsy for genes like TMPRSS2, PCV, I believe, is one of the other genetic lesions, and using those as biomarkers, if you will, when you start treatments with these newer drugs, all right?